Hi, this is Dr. Ustamani Ahmed, hematologist. I'd like to go over anemia classification. This is an introductory session. It's meant to be a general information. More specialized or specific talks will be presented later on. So anemia is a common presentation to doctors usually, either GPs or surgeons or subspecialized people, and definitely one of the commonest presentation to hematology. Definition of anemia is basically reduction of hemoglobin concentration of the blood. Typical values: men less than 13.5 grams, and whenever hemoglobin level less than 11.5 in females is considered to be anemia. So there are some important factors. Newborns are usually having high hemoglobin levels. Neonates from age 3 up to puberty, there are sort of general rule: if the hemoglobin less than 11, we consider it to be anemia. Other indices usually follows hemoglobin, like PCV or packed cell volume and hematocrit. Some labs and some regions, they concentrate more on hematocrit. Hemoglobin is more universal, and there's some factors actually affect the results as well, is the hemoglobin concentration with the plasma volume. We do know the circulating blood in the blood vessel contains plasma and cellular cells like red blood cell, white cells, and platelets. So the degree of the hydration of the plasma affects the concentration, obviously. For example, in severe dehydration, we tend to see high hemoglobin. This is just a false artifact due to reduced plasma volume. In the contrary, in pregnancy, you see the other way around, where you see the volume expansion during pregnancy due to hormonal changes, and obviously you see low hemoglobin. Clinical features of anemia, I think, is very common. Most of populations do know about it. Usually paleness, general sense of fatigue, inability to do daily activity. There are also skin changes, dryness, also paleness and loss of hair in female, obviously. Some severe cases, if you find some stomatitis or cracked lips angles. And it depends on the degree of anemia and the acuity of it, meaning how fast it went down. Cardiovascular system is very adaptive system, where usually adapts to the changes of circulating volume. So as you lose blood, the circulating volume does get compensated by increasing the stroke volume and tachycardia. And usually that's a manifestation of anemia. Most patients get tired easily. They feel their heart beating with any exercises. Another changes we do see with the adaptability of the system is dissociation curve, as hypoxia or loss of hemoglobin. There is some agility of the hemoglobin and the red cells to get out or release the oxygen from the hemoglobin. Important point: long-standing anemia could be silent. So patients on chronic losses like either GI tract, urinary tract, usually take time, and the body is usually able to compensate. Some manifestations that would we see in hematology: patient gets referred because anemia, because of the bleeding, and you investigate that, you find patient is anemic. A couple of studies were performed in cardiovascular patients who went to intervention. There were evidence of tendency to bleed with low hemoglobin level. So whenever you get referred to a blood doctor or to a general doctor, whenever you feel tired, the initial steps to do blood count. So anemia usually presents with low hemoglobin, low hematocrit, and low PCV, which is packed cell volume. Special occasions that could help you to diagnose further is the causation of the hemoglobin. For example, iron deficiency anemia, you tend to see low MCV volume, low MCHC volume, low ferritin, low serum iron. These are indicative of low iron concentration in the body. And another factor that helps you, RDW, is the width of the red blood cell. Platelets usually tend to be high, and heretics could be high or could be normal for iron deficiency anemia. Another situation, you see hemoglobinopathies, which are reduction of production of heme proteins due to genetic reasons, and usually manifest with low hemoglobin, low MCV, low MCHC, and usually you tend to see normal hemoglobin, normal ferritin value, normal red cell width, but usually there is ineffective erythropoiesis where you see breakage of those proteins or of those red cells into high bilirubin and high retics as a compensatory mechanism. Another situation is B12 deficiency, which is very important in cooperating the globulin, and usually you see high MCV volume, big cells, so the volume of the red cells are big, and unfortunately they're ineffective because they get to be broken down, and they release the enzyme lactase dehydrogenase, and they end up also having high bilirubin. Hemolytic picture, which is our red cells are broken up due to cellular problem, due to effect of some external factors from the cells. Usually tend to be, you see high MCV due to retics are bigger cells, which are immature. Then also LDH are released from the broken up cells. Retics as a compensatory mechanism usually high, bilirubin high, and uric acid is high. Some anemia consideration, whenever you have patients with low hemoglobin, think about it, what's the next step I have to do? The age is very important. Younger patients, you tend to think about hemoglobinopathies, or for neonates, think about neonatal anemia secondary to mismatch, ABO mismatch, etc. The younger patients, you think about inherited anemias, like hemoglobinopathies, G6PD, pyruvate dehydrogenase deficiency, and these kind of things that manifest as anemia. Younger patients, they think about PNH, which is a very rare disease, paroxysmal nocturnal hemoglobinuria. Others, you think about post-infectious process, like post-mycoplasma, immune-mediated, could be due to drug, rarely, and most of these drugs were actually out of use right now, but we've seen it. Elderly, you think about, could be a loss, a real blood loss, and that requires attention to gastrointestinal tract or to gastrourinary tract. The question is hemolytic picture. Hemolytic picture also, it could be part of hemoglobinopathy, it could be part of immune-mediated, it could be part of other manifestations. So you have to work it up. Later on will be explained how to do that. When shall we do the bone marrow? Definitely we don't think about bone marrow initially when we see an anemic patient, but there's some trigger factors: long-standing anemia, poor compensation from retics, elderly patient, other cellular abnormality like low white cell count, low platelets, or suspicious for malignancies or for infectious process going on. We think about performing bone marrow. That's it for the introductory session of anemia. hoping that helped you to understand our definition of anemia, our initial approach to anemia. In the following sessions, we'll be expediting more the diagnosis, the reasons for anemia, and how can we correct anemia if it occurs. Thank you.